Welcome to the Explainer. Today we're diving into a big one, wide complex tachycardia. This is one of those situations where every single second and every decision you make absolutely matters. Okay, let's just jump right in. Picture this. You walk into a room, the monitor is screaming at you, the rhythm on the screen looks wild, and your patient is clearly in trouble. What you do right now, in these next few seconds, is critical. So what's the very first thing you need to assess? So here's how we're going to break it down. We'll start with the tachycardia challenge itself. Then we'll hit the single most important question you have to ask. From there, we'll explore the path for an unstable patient and then the path for a stable one. And finally, we'll cover some really critical warnings and special cases you just can't forget. All right, first things first, let's really define what we're dealing with. At what point does a fast heart rate go from being just fast to being the problem you need to solve right now? As a general rule, a patient usually starts showing symptoms when their heart rate gets up over 150 beats per minute. Now, if you're seeing signs of trouble, but the rate is lower, say 110, maybe 120, you've got to start thinking, what else is going on here? It's probably an underlying issue, like heart failure, that's actually the main culprit. Okay, and this is where it gets really interesting, because pretty much everything you do next, every medication you consider, every move you make, it all comes down to one simple but incredibly important question that you have to answer on the spot. And here it is. This is the big fork in the road. Is your patient stable or unstable? Think of it like two completely different paths. On one path, the stable patient. They're alert, they're perfusing just fine. But on the other path, the unstable patient. They're confused, maybe showing signs of shock. And which path you take, well, it changes everything. So let's say your patient is on that unstable path. They're confused, their blood pressure is dropping, they look like they're in shock. Well, the protocol here is crystal clear. It's direct, and it's all about one thing, electricity. When a patient is unstable, you have to act fast. Your number one priority is immediate electrical therapy. Seriously, this isn't the time to be fumbling for an IV or thinking about drugs. Your only goal is to hit the reset button on that heart's electrical system. The best way? Synchronized cardioversion. But if you can't get that set up, then immediate defibrillation is your only move. Okay, so let's shift gears completely. What about the stable patient? Well, this is a whole different ballgame. Here, the approach is much more analytical. You actually have a little bit of breathing room, a luxury, really, to think through what to do next. Because you have that time, you can start asking, okay, what am I actually looking at here? Is it ventricular tachycardia, which, by the way, is usually the most likely suspect? Or could it be something a bit less scary, like an SVT that just looks wide because of a bundle branch block? We call that SVT with aberrancy. So the stable pathway is way more methodical. You'll start by getting an IV, just in case. Maybe try some vagal maneuvers. Your go-to drug, your first choice, is going to be Amiodarone. Now, what about adenosine? Well, you can think about it, and this is a big but, only if you can tick 3 boxes. The rhythm has to be regular, it has to be monomorphic, and you have to have a really strong feeling that it's SVT with aberrancy. And this right here just drives home how careful you need to be. It's an absolute must. Before you even think about pushing adenosine, you have to have the defibrillator pads on your patient. Why? Because sometimes adenosine can make things a lot worse really fast. And if that rhythm deteriorates, you need to be ready to shock them in an instant. All right, now let's get into the plot twists. These are the special cases and the absolute no-goes that you have to know. Because, honestly, getting these wrong can be a disaster. So up until now, we've pretty much been talking about this kind of rhythm, a regular, monomorphic wide complex tachycardia. See how all the QRS complexes look the same? They're uniform? This is your classic case where you just follow those stable versus unstable paths we just went through. But what if the rhythm looks like this? It's irregular, it's chaotic, and the QRS complexes are all different shapes and sizes. This, my friends, is a polymorphic wide complex tachycardia, and it is a whole different animal that needs a special kind of treatment. So here's the key takeaway for this one. If you see a polymorphic rhythm, which might be that specific twisty pattern we call torsades des points, you have to add magnesium to your treatment plan. That's on top of everything else, like defibrillation. Okay, huge red flag here, a major warning. If you have even the slightest suspicion that your patient might have Wolff-Parkinson-White syndrome, WPW for short, do not give them adenosine or any other nodal blockers. I repeat, do not. In a WPW patient, blocking the normal electrical pathway can actually speed up the ventricles to a dangerously fast rate. It's the exact opposite of what you want. And here is the absolute, non-negotiable, carved-in stone rule for any wide complex tachycardia. I don't care if it's stable, unstable, monomorphic, whatever. You never give calcium channel blockers like diltiazem. They can totally crash the patient's blood pressure and lead to cardiovascular collapse. Just don't do it. And finally, for any stable patient, it's so important to remember that your work in the field is just the beginning. The goal is to get them quickly and safely to a designated cardiac center. They're going to need more tests, more expert care to figure out exactly what caused this in the first place. So, there you have it. We've walked through the whole algorithm, right from that first crucial question, stable or unstable, all the way through the treatments. But here's the final thing to keep in your mind. Just managing the rhythm, that's only step one. The bigger question you're always left with is, why did this happen? And figuring that out is the next and just as important part of taking care of your patient.